Welcome to Elevate Louisiana Engage podcast. Elevate Louisiana was founded earlier this year to empower women leaders throughout Louisiana by connecting and educating them on the challenges impacting our state with data-driven, nonpartisan solutions to make a better future for Louisiana. Hello, I'm your host, Julie Stokes. Today we are recording the first episode in a series on the state of healthcare in Louisiana. Our guests today are Dr. Rebekah and Kathy Kliebert, the last two people to serve as the Secretary of Louisiana Department of Health, formerly known as the Department of Health and Hospitals. Dr. Rebekah is an obstetrician gynecologist who currently serves as the CEO of Healthcare Services for LSU Health. Prior to her role as Secretary of the Department of Health, she served as the Director for Birth Outcomes for the Birth Outcomes Initiative. In 2017, Dr. Gee was elected to the National Academy of Medicine. Kathy Kliebert is a licensed clinical social worker who currently represents the Louisiana Medicaid Managed Care Organization Association. Prior to her appointment as the Secretary of the Louisiana Department of Health, Kathy served as the department's Deputy Secretary, where she provided leadership to the agency's program offices for 28 years. I'm proud to also say that she is a founding board member of Elevate Louisiana. The Louisiana Department of Health is the state's largest agency with a budget of $14 billion. It encompasses public health and other direct service programs such as Citizens in Need of Behavioral Health, Developmental Disabilities, Aging and Adult Services, Emergency Preparedness. Also, they oversee licensing in the restaurants and water safety around the state, and also the Medicaid program. The mission of the Louisiana Department of Health, which from here on we'll refer to as LDH, is to protect and promote health and to ensure access to medical, preventative, and rehabilitation services for all citizens of the state of Louisiana. So welcome, guys. I watched the complex relationship, between LDH and the legislature through two very different administrations, the Jindal administration and the, I like to say, John Bell Edwards administrations. The tension between the department's goal of ensuring access to medical services and the legislative pressure to hold down spending would seem to make for quite a tricky tightrope to navigate at times. How hard is it to balance the high healthcare needs of Louisiana's population and the pressure to spend less on healthcare?
I'll start. I think a lot of it has to do with the fact that the legislature doesn't always understand what the healthcare budget really means and is, all the things that are, you just talked about that are included in it. But also, I think more importantly is that they don't really understand how healthcare costs have risen over the year, not just for Medicaid or for public healthcare, but how they've risen in private healthcare as well. So, if you look at our trajectory in terms of healthcare spending, it is certainly no different than the trajectory in terms of private healthcare spending. And again, I don't think the legislature really understands that, and getting that message across when legislators really only hear the rhetoric of, we're spending $14 billion. This has got to be too much, rather than really listening to what is included in that and all the facets of why those healthcare costs continue to rise, which are not at all a part of the department's administration. We're not the ones that are costing the healthcare to rise, but they seem to believe that because, again, the rhetoric is we're just spending way too much on healthcare.
Yeah.
Dr. Gee. Yeah, so as a practicing physician and somebody who has unfortunately lost my first husband and my mother, and one to cancer, one in an accident, and as someone who has been a patient and has required the use of a wheelchair at one point and other healthcare services, I cannot, I can summarily say that there is nothing more important than health. Health care is only a piece of health, but it's an important piece. I believe that health care is a human right. This is the wealthiest nation on earth, and surely we can provide basic health care to the people of this nation, which is what we did when we expanded the Medicaid program. However, I think Kathy so eloquently stated, there are so many complexities to state budgets, and often legislators are not coming from a place of healthcare. They're not physicians. They're not working in a healthcare field like Kathy and I were trained to do. And so they're trying to make sense of all of this. And unfortunately, state budgets are a zero-sum game. You spend more money on health, that means you spend less on education or corrections. The thing that's often missing in the discussions, I think Kathy stated so well, that healthcare costs are rising, not just Medicaid. In fact, Medicaid is rising at less of a rate than private insurance. But what Blue Cross can do is raise your premium. What happens when Medicaid prices go up is that the healthcare budget goes up. What was also missing was that we have lost a lot of the civility that has been such an important part of the democratic process, and we've lost a focus on facts. And so it makes it very difficult to have discussions when we're focused on ideology and not facts. And the facts are that most of the budget of the health department is federal. Louisiana, unfortunately, is one of the 3 states in the nation that is the lowest income, meaning that more than 40% of our people live below 200% of poverty. And just to put that in perspective, that's a single individual making around $19,000 a year. And so there are many people that simply can't afford premiums that often cost $500, $600, $700 a month. And so Medicaid has been very helpful. And a healthy population means a working population, which allows people to have jobs that are sustainable and so on. So it's a complex discussion. I do think that healthcare, we spend in the US nearly twice as much as any other industrialized nation. The issue is this is not a unique problem to Louisiana. We need systematic approaches to the cost of healthcare as a nation. We need to reduce waste and inefficiency. But I believe we can do that and cover the cost of healthcare for all people in Louisiana. And unfortunately, the debates often centered around, an individual or very few individuals who are abusing the program and we're getting Medicaid and we're not eligible, and who are responsible for a small fraction of spending, rather than how do we reduce the overall cost by focusing on the healthcare that matters. And I think that's a discussion that COVID has brought to the table, and something that in the future I hope to be a part of.
Yeah. And well, I just opened up another speaking engagement recently with the post-truth era, and I do think healthcare spending is very complicated. I mean, it's more complicated than the state budget. When you look at how we finance the cost for our hospitals and our, the medical professionals all around the state to provide care to our people, it's very convoluted. So it's susceptible to a lot of rhetoric. I'd like to talk about the spending because when I was in the legislature, I did an analysis. It was a long time ago. It was pre-expansion or pre-Medicaid expansion, but it showed that we were not really spending more on patient care per patient once you adjusted for inflation, but that the number of people on Medicaid in Louisiana had skyrocketed. And I wanted to get a little bit more information on that specifically from Kathy Kliebert, because she was there prior to Medicaid expansion.
Yeah, and that's absolutely correct. I mean, it wasn't that we were spending more per person. It was simply that we had more individuals who needed services. And we're going to talk about this a little bit later. But I mean, we were spending healthcare even prior to Medicaid expansion for these individuals. And, most individuals that were on Medicaid prior to expansion were those individuals that had disabilities or were elderly that had disabilities. We're not talking about the working population. We were talking about people that were either had a developmental disability or an age-related disability. And again, as a population that like we have with such high poverty rates, you are going to see more of that population. And that's what we saw. I mean, again, wasn't that we were spending so much more per person, or that we were, that we weren't controlling healthcare costs, which is what the pressure, we always want, you've got to control these costs. No, it had to do with our population and the needs of the state that frankly are very significant in terms of healthcare.
One of the things I learned in the legislature is that, I mean, until your populace is properly educated and healthy and able to work, we're gonna suffer in this state, you know, and it was a hard thing to see. You know, Dr. Gee, it was always said that Medicaid expansion actually ended up saving Louisiana money. I mean, could you explain how that could even be true?
Yeah, so typically your Medicaid, well, all Medicaid programs are a blend of federal funding and state funding. And the state funding or the state share is determined by the general wealth of that state. And as I mentioned earlier, Louisiana is one of the lowest income states in the nation. So, but we still had to pay, the feds only paid 67 cents on the dollar, and we had to pay the rest. When we first expanded Medicaid, it was 100%. So no cost whatsoever to the state to enroll folks. And as a practicing OB, I can tell you that many pregnant women would lose coverage, have no way to get on. And as Kathy mentioned, they would go to an emergency room. And there are laws that require us to cover people who go to an emergency room. So we were paying for care, but we were paying for the worst possible kind of care, emergency care, care for things that had conditions that had gone too far, that couldn't be treated anymore in an office. And so we were able to save money by allowing the federal portion to take care of those costs and to start shifting the spend from emergency care into primary care. And we've seen the emergency care rates go down over time. And we, in fact, were 8th highest in the nation in terms of utilization of primary care the last year I was secretary. We made significant strides in breast cancer screening, 80,000 plus breast cancer screens, 50,000 plus colonoscopies. Those are things that pick up cancers before they're too far developed. And what we know is when people are really sick or cancers are too far gone, the care is actually very expensive. So part of it is the federal share, and the federal share being greater, and that helped the state. And in fact, when the governor and I started, we inherited a $2 billion budget deficit. And the new dollars that came from Medicaid expansion were able to help us alleviate the need to cut hundreds of millions of dollars of state services from other programs. And in addition, you know, the federal dollars bring money for not just healthcare services, but you know, food services, dry cleaning services, all the things that have to happen for 500,000 people to get care are also supported through those dollars. So it was a help to the economy. And not only that, the estimates were that at least 15,000 jobs were created, at least. And so it was a job creator. It was an economic boom at a time when we desperately needed an infusion of dollars into our economy. And as one of the lowest income states in this nation, we actually benefit more than other states because we get more federal share. And even now at the lowest point of the federal share, it's 90%, which, as I mentioned earlier, even in a low income state only goes up to about 67%. So we're at 90%, and we're able to stop paying for uncompensated care. And so it's a good thing for our economy, and it has shown in the years since the expansion to continue to be a good thing for the economy.
And that's actually one of the things that's going on right now today, where a lot of TV is taken with the passing of Ruth Bader Ginsburg, and talking about overturning, if the Supreme Court were to overturn the Affordable Care Act, what would happen here to healthcare in Louisiana? I mean, how would it impact? Would it take that Medicaid back, or how would that work?
It would, Julie, it would be catastrophic. Because of COVID, so many lost jobs, 530-some thousand people on Medicaid, they would all lose it because the state would no longer be able to afford the state share, which would then go down, the state share would go up to, instead of being 10%, to be 30% or even more of the cost of Medicaid. And also the Affordable Care Act allowed individuals to be on their parents' health plans until age 26. It also allowed individuals with pre-existing conditions like breast cancer to get coverage. So many people with cancer would lose their coverage. Many hundreds of thousands of working Louisianans would lose their care, and it would have a catastrophic impact on our state.
And And there have been some legislation that, some preliminary legislation that was put in place last year, and there would need to be additional legislation to cover some of those, those, as Dr. Gee said, the obligation to cover children after 26, all those things. There are some things legislatively that could be done to ensure some of those protections remain in place. But again, a lot of things would have to happen to ensure that we can continue with the Medicaid expansion benefits that we've gained.
And one of the things that's frustrating for me is that there are individuals who have criticized the Affordable Care Act. And I certainly agree that there are things that could be improved, but instead of having a substantive policy-oriented discussion about what needs to be improved, it's just been an attack on the Affordable Care Act. And instead of finding a replacement, which certainly the Republican members of Congress have had much time to do, they were not able to successfully find a replacement or to present an alternative vision that the Congress or the country could support. And so the issue is there isn't an alternative vision. So, in my view, it's not that you can't improve on the Affordable Care Act, or you shouldn't think about how we should reform American healthcare. It's that you shouldn't pull the rug out from under millions of Americans without a very good idea of what you're going to do instead.
Yeah. And as Dr. Gee said, I mean, we all agree that there are reforms needed, and not just in Medicaid, but in our overall healthcare system. We're paying for the wrong things. We're paying for emergency room visits. We're paying for urgent care rather than preventative care. And, we really have to look at those things. Those are much more significant in terms of cost drivers than adding more people to the rolls. I mean, a lot of people think it's adding more people to the rolls. That's not what it is. It's really about figuring out how to have those Medicaid reforms in a system that allows people to have that preventative care.
One of the things that I think at one point right after the Affordable Care Act passed, people might have known this, but it's kind of getting a little fuzzier for people. But I know that there's Medicaid is at different socioeconomic levels, and that is everybody below a certain percentage of federal poverty level is on Medicaid. And then above a certain amount, you have the exchanges that you can get insurance from.
Yeah, it's 138% of the federal poverty level. Anybody below that, which for a family of four, it's a little over 35,000. So again, we're not talking about high income. We're talking about individuals who are the working poor, who are working, but they're not making enough to pay for health care. And so, again, it's a low bar that they have to reach in order to meet that. So it's not, like I said, it's not a high income level, a threshold to reach, and it's significant for those individuals that, otherwise could not have afforded healthcare.
Yeah.
And you're not automatically enrolled in Medicaid. You have to enroll in Medicare is if you're over 65. So some people are dually eligible, so they may have a disability or a poverty that would justify they're on Medicare and Medicaid, but most people are on Medicare because of age. And those are the two programs that make up about 2/3 of the healthcare budget of this country. And then the rest of it is in a private market. So you either have the exchanges, which you can get on, and usually those are their enrollment periods. One thing about Medicaid that's different is you can enroll at any time. With the exchanges, you have to enroll only in open enrollment. You have to have a change of life circumstance, marriage, death, change of job, or certain times of year, and you have to pay a premium. And those are things that many of us think probably need some reform, because the premiums and the exchanges have gone up quite a bit, and you don't have the competition maybe that's needed. And so there's a lot of discussions, but I think everyone puts it all into one bucket because their frustration with it. But it's really a series of different problems that need to be solved and addressed, maybe with different solutions.
Yeah. Well, and one of the things that I remember coming up while I was in the legislature this was part of the thing I thought was probably a real problem, was that if to apply for Medicaid in the expansion population, that if you were without income for a couple of months, but you had made a lot of income prior to that, you could apply for Medicaid and what was that? Because there was something that we dealt with that, you know, if you didn't, you know, one of the things was when we were trying to address issues of how much people made and matching it to income taxes and everything. And it really didn't matter because the statutes federally allowed people to get on it maybe when they had been out of work for a time.
Julie, thank you so much for reminding me of that. No, look, so what happens is people lose jobs, right? They change jobs, their circumstances change, and Medicaid eligibility is determined by the status of that individual at time of application. And so we did implement a new eligibility system. The system that was in place when Kathy was secretary was outdated, and you know, there had been planned for quite a long period of time to replace it, and we did implement a new system which was much more laser focused and able to identify people's income in better ways. But regardless of that, we're criticized. But it is important. Obviously, this is a program that is for people that should be reserved for people who need it. And individuals shouldn't abuse it who don't need it. And if you can afford to buy insurance, you should buy insurance. And we have a lot more safeguards in place now with the new system that was put in than we did before, just because technology hasn't improved. And the new eligibility system we put in was the largest single technology change in the state's history. It was a huge undertaking, but I think a very important framework and foundation for the system, which should have integrity. And so that was a big focus during my time as secretary is improving the integrity of the eligibility system so that we can sustain it for the long term.
Well, it's great that y'all were able to accomplish that. It's so important. So a lot of people around the state might not know how Medicaid is administered here in Louisiana, but it's delivered through, it's a privatization contracts
Right.
under the umbrella of Healthy Louisiana. And I know when I got into the legislature, it was called Bayou Health, and I didn't even know about it. So I think a lot of people that are listening probably don't understand how it works. And I know that Kathy Kliebert is working in that area a lot, and I was just wondering if you could explain Healthy Louisiana.
Sure, and I do think a lot of people think Medicaid is just a state-run program where you go to the doctor and the state pays for that service. It's actually run through private insurance companies, just like your healthcare or other people's healthcare, private insurance. It's run in the same way. There are 5 plans, Medicaid plans, that are operated with contracts through the department. That's Aetna, AmeriHealth Caritas, Healthy Blue, Louisiana Healthcare Connections, and United. And those 5 plans, again, operate as any other private health insurance, meaning they have prior authorizations for services. Some services have to be prior authorized, just again, similar to private insurance. There are some services that aren't covered by Medicaid. There are services, some services that you have to go through a process to make sure that, again, it's related to the diagnosis, for the treatment is appropriate. So there are clear limitations on those services, and again, very, very similar to what it is in private health insurance. There are also, this is probably the biggest benefit of running through a private program, is there are disease management programs for hypertension, for diabetes management, for screenings. Dr. Gee talked before about colorectal screenings and breast cancer screenings. Those are all part of the wellness programs that these companies operate. And it's extremely important for long-term care cost, meaning that, we save in the long run if we can detect these issues early on. And having disease management programs run by these private companies allow us to do that preventative care and save in the long run in terms of high cost of utilization. It also allows people to use a primary care physician rather than having to go to the emergency room for their care. So again, we like you said, I think a lot of people think this is just a government program. You just can walk up wherever and get your service, when it is absolutely has utilization management, very similar to the private insurance programs that other people have as well.
Well, and I kind of and tell me if I'm wrong, because I could be, but I liken it to how a lot of people in the Medicare population, they go out and they get a Medicare insurance policy that takes that that capitated or per person per year, it's actually per member per month, whatever, and pays that to that insurance company to manage that person's care. Isn't that a lot what it's like?
Yes, it is. It's a capitated program, and it helps in terms of also budget predictability for the state as well, because rather than, again, not knowing how much this person is going to cost, there are actuarial methods that are put in place to look at cost and figure out how much it costs per person per member per month. So again, and it's capitated. At that point, the health insurance programs take the risk for those services. And if they go over that for that person, they are the ones that take the risk. So they have incentives to try and reduce those costs per person by, again, putting in preventative programs and other things that will help in terms of reducing those overall costs.
Yeah, one of the things that I got to do while I was serving was to take a tour. It happened to be Louisiana Healthcare Connections, and go take a tour of their offices and learn more about how they did things. And I thought it was just so, I had such a positive feeling from that visit, because they were on the phone getting in touch with members to make sure they had been to their primary care doctor, making sure, following through on people that maybe were supposed to get some sort of diagnostic procedure from their primary care visit. And I thought, wow, this is just so much more productive than the reactive sort of care that we were giving under, show up at the emergency room when it all goes south,
Absolutely.
So shifting focus a little bit, obviously we have been living in the middle of the first public health crisis, I think, to my awareness, that's been as large scale during my whole life, and that's COVID-19. And, I just wonder, how do you think the state's done, performing in its handling of COVID?
I think they've done an excellent job. I think they've utilized the data that they had and the guidance they've had, both state and federal guidance they've had, to make good nonpartisan decisions. It's one of the few areas that I have, not just me, but also my friends that are of the conservative nature have said, the administration and the department have done a really good job of balancing the public health emergency and the public health risk with the economy, and trying to make good decisions based on the data that they've had to balance that, and to assure that we can ensure public health safety at the same time that we're trying to assure we're not devastating the economy. And it's been a very, very hard thing to do. But again, I think the state has done a very good job. And I think when you look at other states and how some of them have handled it in a much more partisan way, I think you will see that this state has really handled it in a way that tried very, very hard to, they didn't go down this hard line of, we've got to just shut everything down and, and because of the public health emergency. But at the same time, they took precautions that made good common sense and allowed the economy to open as those, as the data would guide them. And again, doing that, I think I think the decisions were made in very much a nonpartisan way. Very pleased with that.
Kathy, really well said. And I also wanted to just acknowledge that I inherited a department that was passed off to me with a relay baton of incredible talent. Kathy and Bruce before her, and Secretary Levine and Fred Cerise, and just so many good people. Bobby Jindal. People have led the department who are smart and thoughtful, and Louisiana has made good decisions throughout a long period of time. We have protected public health. We're one of the few states that has public health entities in every parish that has a footprint, and that was priceless when COVID happened. It gave us the opportunity to understand and act and activate in local communities. We also built on a lot of the data infrastructure. When I became secretary, my background is in health services research. So I use data to make policy decisions, and I'm trained in data evaluation. We created a Medicaid expansion dashboard, but fostered the skill sets that had been also fostered by Kathy to look at how you use the data to act and to inform good decision making. And that was the same team that then built the COVID dashboard. We have a great governor, someone that I stood by for 4 years and got to watch him and watch his decision making. He's someone who makes decisions based on data, but he's always willing to listen and hear both sides. And so we've had great leadership, and we can see that in the rates that we have. It's just, as I like to say, the proof is in the pudding. So all you need to do is look at Texas, look at Florida, look at what's happened there, and you look at Louisiana, and it has not been an easy journey. I live in New Orleans, and here, in part because of some of the festivals and congregations that were happening when COVID was spreading, and before we knew it was spreading, we had one of the highest growth rates in the world, higher in fact than even Northern Italy, which many of you probably saw what was happening there. And we were able to contain it through good leadership. And I think that that's a tremendous thing to be proud of. But I also think it's part of the Louisiana spirit. I think it, you know, when we see a disaster happen and we watch the Cajun Navy, Louisianans don't have to be told to help, they go and help. And when we were told to wear masks, it wasn't a struggle for most people. We wear masks everywhere I go. People wear masks. I was driving to work today, even homeless people in New Orleans are wearing masks. And so I think the spirit of wearing masks to protect each other has been strong, and it's paid off. And good leadership informed by good data and a good foundation of public health has really meant the difference for a state that really could have looked very different.
Well, my very first videocast that we did was with Jennifer Avegno in New Orleans, because it was in the early days of COVID, and you know, a lot of us were very scared at that time. And yeah, I've watched all these leaders emerge, you know, and I am proud of the way we've handled it. And I think that COVID has actually probably changed healthcare in a lot of different ways. And you know, I was just curious to see what you guys think about that, because honestly, I think that it's going to have changed life in general in so many ways. How many people are going to want to go back to an office setting? How many people, you know, just want to change the way they do things? And how did COVID change healthcare?
I think one of the biggest areas initially, and that is ongoing, is the use of telehealth. And, you know, we have, you know, certainly, and I think Dr. Gee feels the same, you know, we always knew this was a viable option for use in healthcare. And again, rather than use an emergency room or even urgent care, to be able to use, you know, talk to your primary care physician or a teledoc through telehealth is a lot more economical and saves people a lot of time. You know, working families that struggle to get to those primary care, you know, appointments, you know, I think the whole and behavioral health, this whole emergency has really pointed out that there are some clear opportunities to use this and use it well. I mean, there have to be, you know, certain limitations around it, but it has worked really, really well to offer another option in healthcare that, like I said, I've always felt should have been you know, more expanded use, and this has shown it can work and did work during the crisis, and I think will continue to work as we move forward, and it'll be a big part of the change in healthcare, I think, in the future.
Yeah, well, I can tell you, I mean, I love it. And I mean, I've been going to, it's my own doctors, you know, I'm still going to the same doctors, but I'm able to connect with them when they don't have to do a physical exam this way, same as we're doing right now. And I mean, I've had 5-minute doctor visits where you just don't have to drive there. You don't have to sit in a waiting room. Right. You're in and out in 5 minutes. And that's pretty amazing. Dr. Gee?
I agree with Kathy. I think telemedicine is really exciting. And as a parent of 5 kids, I can tell you, I use telemedicine, but it's because I'm a doctor and I can text my doctor friends and say, what do you think of this rash? See the picture. And that's the kind of thing that everyone should have access to. And I think it's really exciting. I'm actually serving as co-chair for a national group called Health Evolution that has CEOs from the big companies, including the managed care companies that Kathy represents, to try to figure out how to use all of this, the disruptive forces that have happened for COVID to help us innovate and change, because I think we don't want to go back. Those of us who have used telemedicine and have had access to it, we want it to stay. And so the question now is, how do we pay for it? How do we know what the quality is? I just served on a task force to look at quality of telemedicine, and we don't know a lot. So there's a lot of questions, but a lot of exciting opportunities. And we've seen a technology revolution out of COVID, whether it's the Apple and Google app that will use Bluetooth technology to help you know if you've been exposed, or lots of other technologies. We've seen that the human spirit can innovate, particularly when under pressure, and the whole world is innovating. The novel development of a COVID vaccine. We've never in our lifetime seen something happen so quickly. So it's really exciting about what can happen with science and where we are. But I think it also reminds us of the importance of public health, something I hope we'll invest in greater. We know now that if we had these infrastructures in place, if we had lab testing, if we'd had better data surveillance systems, we would have saved many, many lives, and potentially, I mean, I don't even want to make up a number, but billions of dollars. So we need to have public health. It's something that it's kind of like an insurance policy. You don't need it until you need it, but when you need it, you really need it. And so hopefully we will learn. And then finally, I think that COVID's reminded us of the importance of good health generally, that we need to think about the health of our nation, and that we have to be mindful that we have to try to be healthy, have healthy behaviors, and have a healthy population, so that we can do better with COVID. And it's been really hard because our population in general in our country, and particularly when you're in areas that are lower income, like Louisiana, we have a greater burden of chronic disease. We have more vulnerabilities to COVID. And so I think it is also a challenge to us to think about, how do we get healthier as a nation, and what are those things we can do? Because my concern is this may not be the only time in our lifetimes that we're exposed to something like this. So how do we get ready for the next virus that hits, both through creating public health as well as helping ourselves be healthier?
Yeah, and how do we learn from, some of the big issues that occurred in the first couple of months and still continue, are people not getting preventative care, right? They're afraid to go to the doctors, or they've put off their screenings, or for children immunizations. Really big worry of mine is, people are putting off those preventative health type of things. And providers have had to be innovative, because, their offices have been closed down for months. And, so how do they, do things differently? So again, I think a lot of them have innovated in the telehealth world, which has been very, very, good. But I think there's still a lot more innovation that will need to occur, so that we can make sure that during a crisis like this, people can still get their preventative care. They can still, have that contact with their primary care physicians.
Yeah. Well, it's been so great to talk to you two today. I'd just like to thank both of you for being here. I love this bipartisan look into healthcare in Louisiana, and the fact that, we can be of different parties and we can sit here and talk through things, and we've got more in common than we have different. So thank you, Dr. Gee, and thank you, Ms. Kliebert.
Julie, if I could say this, though, I think your leadership is extraordinary, creating Elevate Louisiana, and I admire Kathy so much, and she and I agree on many, many things. In fact, agree on more things than we disagree on. So thank you for being such a wonderful leader, and for bringing me and Kathy together. It was wonderful to have a chance to see and talk to her.
Yeah, and I totally agree. And as you know, how much I respect you as well, Dr. Gee, and respect all that you've done and all that you stand for in terms of healthcare in Louisiana. And thank you, Julie, for doing this, because it really shows how we know what the solutions need to be, and that most of these solutions clearly are nonpartisan. And we just need to figure out a way to make those policies a reality. And I think this helps.
I love it. I'm so excited that we had the two of you on. I hope a lot of people watch this video, because it's really been neat, and it's been a pleasure to get to know both of you guys. I consider you both friends. So that is about all the time we have for today. But for those of you who are listening, if you're interested in joining Elevate Louisiana, visit our website at elevatela.org. That's Elevate with 2 L's. You may also listen to all of Elevate's Engage videos, interviews on platforms where you find your podcasts. So if you don't want to sit in your chair or wherever you sit to watch video, you can listen as you ride your bike or take your walk. Finally, don't forget to like Elevate on all your social media platforms and share this videocast on your page if you found it interesting. I'm your host, Julie Stokes, and we'll see you next time.